So I'm going to be talking about Mevrometostat, which is an EZH2 inhibitor, which is in development for MCRPC. I've been involved in this clinical trial due to luck and fate because this is a trial that was actually looking at multiple tumor types, including small cell lung cancer. So Dr. Melissa Johnson brought me in and got me involved when we started looking at prostate cancer. And this is data that was presented at ASCO. You can see this is, it's a phase 1 trial. It's in 3 different parts, and we're going to look at one of those parts because not all of those parts are publicly available yet. But it's a very exciting combination that was presented a lot of data this summer. Now, EZH2 in prostate cancer is difficult to understand, and I've done my best over the last 24 months to really dig into this and try to figure out how these drugs work so I can explain it to my patients in clinic. And I still don't know that I'm 100% there, but it's involved in epigenetic signaling, right? And we know that epigenetics are critical in prostate cancer. EZH2 is a catalytic subunit on something called PRC2, which is very important in methylation of histone 3 at a certain, a very specific spot that is involved in silencing some tumor suppressors, but also perhaps is related to the AR promoter directly to increase signaling through that pathway too. So it's involved in a lot of different ways in multiple solid tumors, but specifically in prostate cancer can lead to metastasis, transformation, etc. And when you think about lineage plasticity, we had a great conversation. I think that was earlier today. It might have been yesterday. Time flies, but a great conversation about this. So I'm not going to go back into it, but EZH2 is involved in many of these steps in different ways, including on the right side of this slide, potentially in neuroendocrine differentiation as well, as pushing patients away from that AR signaling drive. Now, that just complicates it because I did also say that EZH2 is involved at directing to the AR promoter and driving that pathway as well. So that's why this is so complicated and really hard to distill on how best these drugs work, and that's relevant to how do we position them. So this is the phase 1 study, and as I mentioned, I got involved because of the small cell lung cancer interest by Dr. Melissa Johnson. But once we started seeing some signals in prostate cancer, I got involved with the development team and started looking at the prostate arm here. So we're not going to focus much on the dose escalation. We're going to focus on the dose expansion and specifically part 2A, highlighted in green on the middle of this slide. Part 2B is randomizing the combination of this EZH2 inhibitor with enzalutamide versus enzalutamide alone to really look at the contribution of components of this drug. More data will be presented very soon. I can't tell you exactly when, but that is coming and hopefully of interest. So we're going to focus on 2A today. So combination of cohort 2A with mevrometostat and enzalutamide. So the eligibility, I didn't put the whole schema on here, but basically it's CRPC. You've received prior abiraterone or enzalutamide. And then the dosing was at this point still somewhat in flux and escalation. Fixed dose enzalutamide, obviously at 160 milligrams daily with different dosing of mevrometostat. And if you look at on the left side, this is just showing 50% had had prior taxane, right? That's pretty much what we see in a lot of these clinical trials. But 74.5% had seen prior Enza, 57% had seen prior Abi, and then many other patients had seen both Abi and Enza, almost a third of patients. So that is a heavily pretreated hormonal population. Mm-hmm. And when you look at this data that was presented this summer, do you have activity in both cohorts? When you continue on with the enzalutamide and add in this EZH2 inhibitor, whether they've seen prior Abi or prior Enza, there's activity here. Median's very high, 17 and 11 months, obviously a little bit higher in the prior Abi than the prior Enza arm, which is what we could expect because we know that there's a little bit of activity when you make that switch, though there's not a ton, but there's a little bit there. Also, though, this is small numbers, so I do want to caution that. And then this is the PSA waterfall plots. They look pretty good. On the left, that's best change from PSA, and you can see blue is prior Abi, pink is prior Enza, and that's showing that. But if we zoom in onto the right side and also look at change in target lesions in those that are RECIST eligible, we actually see response rates of almost 30% of men with median duration of response of 11 months. So this is a combination of oral therapy prior to and post taxane that could really help men who don't want to do chemo as much as Dr. Schaefer would like them to. I'm just joking. So biomarker analysis, they also looked at some, different mutations that you can pick up on NGS that we all have available in our clinics. And you're seeing activity in patients with or without AR mutations, in patients with TP53 mutations, et cetera. when I look at this data, I'm not sure exactly that this helps us position this asset, but it's interesting to see that you have activity in kind of different subsets of prostate cancer from a genomic standpoint. When you think about toxicity, there is toxicity. Oral therapies carry toxicity, right? So interruption of mevrometostat in about half of patients, dose reductions in about 20%. But remember, this is dose escalation as well. You're always going to get to the point where you get toxic and then have to bring it back down. That's the job of an early phase investigator. So there were some deaths on this study. None of them we think are related. 2 disease progression, 1 stroke, 1 heart failure, and 1 unknown. But these were obviously litigated through all the obvious channels, and none of them seemed to be appropriate to say they were due to the therapy. Now, I didn't put a slide here because it's ESMO data from a different compound, but I should mention the CELO-1 data set was presented at ESMO just a month ago, which was tazemetostat, a different EZH2 inhibitor in the prior abiraterone space. So patients who are progressing with MCRPC with prior ADT and abiraterone, that drug did not reach significance. Now it's a small study, so EZH2 looks good here, EZH2 not so good on that study. They're obviously very different molecules, very different compounds. But of course, this is early phase. Moving it on to late phase, we'll get some more data and hopefully improve patients.